Awesome. So this is going to be Cardiopatho. This will be the last lecture for exam 3. So we'll do an exam briefing next class, but exam 3 is cardiorespiratory. Okay. So we're going to talk about basically when things go wrong. So first off, if your surgeon ever pulls out a heart and holds it up to the light, get a different surgeon. If they have no idea what they're looking at, that's a problem. Okay. All right, so varicose veins. Varicose veins, simply put, is just when blood starts pooling in the different veins there. Okay. Varicose veins, you guys have probably seen these. They are distended, so that means they're kind of like bulging out. Tortuous, not tortuous, but tortuous, which means turny. They twist and turns. You got turns. And they are palpable. So just recapping and tying into health assessment, what does palpable mean? If you poke it, it pokes back, right? The thing about varicose veins, they are painless in development. So again, you would not know that you're developing these until you see them, okay? Eventually, they do go on to cause pain. And I'll explain this. So it doesn't hurt to get them, but once you have them, there's going to be pain associated. Okay. Caused by trauma. So what we're talking about here is we're damaging the veins. What structure in the veins can be damaged? Valves. The one-way valves. Awesome. If I damage those one-way valves, blood just pools below. Okay. Okay, so varicose veins. Yummy. Who's at risk for these? Let me say at risk here. Elderly, absolutely. Who else? People who are on their feet a lot. Like nurses. So are you guys at risk for this? Yes. Do you guys want these? Yeah. It makes bikini season a little awkward. Yes. So let's just say you don't listen to my advice. You don't take care of yourself and you get varicose veins. How do we fix these? Now you don't need to take notes on this. This is just me being a nerd. I forgot to pull this up earlier. So this is one of the methods that we can use to fix varicose veins. Sorry, I meant to pull up all of these links prior. Okay, so I'm just going to pause it here. So here's the varicose vein, yes? What kind of blood is pooling in this vein? Deoxygenated blood, causing what condition? Eventually necrosis, a couple steps before. Before hypoxia. So if you have blood pooling in here, that's going to cause ischemic conditions. Leading the tissue to become hypoxic, that's what causes the pain. Okay?
So wait, just the tissue of the leg?
Correct, correct. At least the tissue here, because the issue which we're going to show, this is going to cause swelling. So now I have a bunch of fluid and deoxygenated blood in my leg. How does that increase or decrease oxygenated blood flow then? Decrease it because there's so much pressure down here. So I got deoxy blood pooling and I can't get new oxy blood in. So that kind of sets up for a storm here. So one of the ways they'll do it is they're going to permanently seal the vein. Basically, we're going to use super glue. Put a little glue down, and then we physically seal that vein shut. all the way through. So that's kind of cool. Another method in which people will, so I worked with a acupuncturist who also had varicose veins. You don't need to write this down. For whatever reason, people of British descent seem to be at a higher risk as well. She had varicose veins. Her surgery, what happened was she went into surgery, they cut the connective tissue along the vein and then rotor-rooted this whole sucker out. Just ripped out this whole vein. Anybody see a problem with gluing your veins shut or tearing out your veins?
Yeah.
Not to the area, from the area, we get less blood flow back, right? The reason why we can do this and get away with it, do veins have pressure? You can actually regrow your veins. You can grow new veins. So she'll grow new ones to replace the ones that we just tore out or the ones that we just glued shut. Either way, how do we prevent varicose veins? Compression socks. So what's cheaper, compression socks or plastic surgery? So what are you going to do before Q2 and you have to stand on your feet for 12 hours? Go on Amazon. People with computers, go on Amazon. Get you a pair of compression socks. Make sure they're fitted properly. There's different sizes. I think Walgreens has a fitting service. They'll tell you which size you want. Okay. Seriously consider getting yourselves compression socks. Or else. Okay. What do I know? I'm a dude. I don't have to worry about what I look like. Let's say you don't heed my advice. This is going to, your varicose veins will develop into chronic venous insufficiency. Exactly as it sounds. Long term. Lack of blood return to the heart. Okay. So you have deoxygenated blood pooling in the leg. That's also going to cause inflammation. We kind of talked about this. You got deoxy blood, you got inflammation in your legs, lots of fluid. That is going to increase pressure. So what does that mean for oxygenated blood flow? More or less to the leg? Less. So that increased pressure is going to cause ischemia. Again, no oxy blood flow. That ischemia leads to hypoxia, which will eventually lead to necrosis. That's your venous stasis ulcers. Venous stasis ulcers. So stasis means not moving. So bless you. So I'm going to say stagnant blood in the veins, leading to holes of necrosis. So the deoxygenated blood and that inflammatory fluid prevent new blood from going down in there. Okay. So that is what a venous stasis ulcer looks like. What was the issue here? Varicose veins, we had this pooling of the deoxygenated blood. What else? Not enough oxygenated blood. How can we prevent varicose veins? How can we prevent venous stasis ulcers? Motherfucking right. Google it, put it in your phone, make a post-it note, get you compression socks. Okay. Now I hear you. It's black and white. This is dated. We have color TVs now. That's what venous stasis ulcers look like. Now let's kind of explore this a little bit here. Somebody develops a venous stasis ulcer because they didn't buy compression socks. What do you think healing would look like if someone's leg was filled with deoxygenated blood and inflammatory fluid.
They like don't, you know, like it's all surgical.
Mhm, mhm. We see prolonged or delayed healing time. Okay, so I'm going to say delayed healing. Secondary to that ischemia. Again, because we can't bring new blood down there. How do we fix this then if this whole tissue is going to start to necrose? Amputation. Eventually, it's going to need amputation. Compression socks.
So, you actually heal, how long does that process normally take?
Great question. So let's just say this, if they had good blood flow, we can heal this, give or take about a month. Depending on how bad their venous insufficiency is, it can take 6 months. 6 months of constant cleaning, changing dressings, keeping it clean. So if you're asking a patient to do something for 6 months, what's the likelihood that they're actually do it?
It's not.
So. Any fun fact, does anybody know how long it takes to amputate a leg? One of my friends in residency during a general surgery rotation was able to amputate a leg first time in 12 seconds.
Wow.
They use a rope saw. It's nuts. So hey, don't chop off your legs, buy compression saws. Okay. All right, so along with venous stasis ulcers, this puts you at risk for a thrombus. Anytime you see thrombo, that relates to a blood clot. Okay, now a thrombus, if you see thrombus by itself, that means it's stationary. Okay, so you guys remember what those legs look like. If a blood clot forms there and stays there, we call it a thrombus. Okay, so it's still attached. However, if that blood clot decides to travel, it becomes a thromboembolus. So a blood clot that is traveling. Okay. If you ever see the term embolus by itself, it just means something is traveling. If you see thromboembolus, you know that something is a blood clot. Okay. So
Would it be a thromboembolus?
exactly. That got stuck in the pulmonary veins. That enrolls. Thrombophlebitis. All right, using a little bit of Latin here, what do you know about a thrombophlebitis?
It's a clot.
It's a yeah, it's a blood clot, and there's inflammation maybe of the vein. Can blood clots get inflamed? Not really. So what this means is it's a blood clot with inflammatory factors. Okay, so what do I mean by inflammatory factors? This is a blood clot with granules of histamine. This is a blood clot with antibodies. This is a blood clot with white blood cells. When you make a blood clot, it's a giant net. We're going to rope everything that's in the blood. This means somebody had a blood clot during an infection. Okay. Arterial thrombi, so it's a blood clot where? The arteries. Venous thrombi, blood clot in the veins, don't overthink it. Which one is more likely? Are you more likely to get a blood clot in the arteries or in the veins? Veins. More likely. And we'll talk about why. Hey, guess what prevents blood clots in your legs? Oh yeah, yeah. That'll do it.
I get made fun of because I wear compression socks over my leg. I'm terrified.
Do it for long road trips as well. Like, oh my God, I'd rather not have a blood clot than have to deal with the effects of a blood clot. Yeah.
My parents were always like, really? Like we couldn't even put baggy spots over them. It's like, no compression.
Deep venous thrombosis. Anytime you see the term osis, this means a condition of. A condition of. So thrombo, you guys know, what does that translate to? Blood clot. Deep venous, these are your deep veins. These are below the waist. Okay. The veins near your femoral artery, their diameter is huge. You could probably drop an entire quarter down your vein. Like their diameter is huge. That's why we call them deep veins. So if you're reading this, deep venous thrombosis means a condition of blood clots below the waist. That's how that Latin translates. Okay. These three factors are known as Virchow's triad. Wink, wink, nudge, nudge. You should probably know the three things that make Virchow's triad. Okay, starting with venous stasis, exactly as it sounds. That sounds stagnant blood. Okay. Venous endothelial damage, so damage to the actual veins. Damage to vessels. Okay. And then a hypercoagulable state. This is kind of genetics. We'll talk more about this when we talk about blood. For now, all you need to know is a hypercoagulable state is genetic. So take, for example, if I'm going to compare Alexis to me, if I make twice as many platelets as Alexis, what's my blood clots going to look like? Bigger or smaller? Bigger. That's a hypercoagulable state. You guys see how that's genetic? So what I want you to focus on are the first two. Venous stasis. Give me an example pathology where we have blood pooling. Give you a hint. It's a pathology we just covered. Varicose veins. Varicose veins. Give me a pathology where we have damaged our blood vessels. Varicose veins. So, varicose veins, what I'm getting at, do they increase your risk for a blood clot? Going back to how do we prevent this?
Compression socks.
Oh, dear God, do you guys get the message now? Okay, I've typed compression socks to 9 slides already. Okay, so Virchow's triad, those three things, they are going to come up. Okay. All right, so this person's having a really bad day. They had a big blood clot. It was a thrombus, but then it started traveling. In fact, it traveled and then it split into 3 parts. Pretty bad day. Okay, so an embolism, remember if you ever see embolism by itself, that just means traveling. Okay, so something is traveling. It can be a blood clot. We would call it a thromboembolus. It can be amniotic fluid. It can be fat. It can be a malignant cancer cell. It can even be an air bubble. Some cancer cells, some sort of form of substance. Okay, air bubbles. This is just an FYI, PSA. Okay. When you guys are working with injections, please, please, please make sure you clear the air out of your injections. Okay. If an air bubble gets into the vein, the surface tension of water is too high. Your body can't pop that bubble. Okay, so it's basically going to cause a clot that you can't remove. The reason why I bring this up here, people die from air bubbles in lines. In fact, in World War II, when the concentration camps were running out of bullets and poison, they just started injecting air bubbles into prisoners. Serious, serious stuff here. Clear your lines, clear your needles. Okay? Just a PSA, but please be safe out there, y'all. All right. So aneurysms, we kind of talked a little bit. Aneurysms are kind of like varicose veins. Varicose veins, they happen in your veins. Aneurysms typically happen in the arteries. Okay. You guys remember we talked about aneurysms in the brain? It's when your blood vessel outpouches, so a dilation or an outpouching, usually of a vessel wall. Okay. The biggest culprit is high pressure. High pressure. That's going to cause your blood vessel to expand out. That's why they are typically going to happen in the arteries rather than the veins. Arteries have pressure, veins don't really. Okay. Weakening can be caused by hypertension, which is high pressure. Atherosclerosis, we'll talk about. Okay. The last one you need to worry about is inflammation. So 3 things that can cause an aneurysm: hypertension, athero, and inflammation. The thing that they all have in common, all 3 of those, increased pressure. Okay, so again, that's why I put a box around high pressure. That's usually the main culprit there. So these are different types of aneurysms. Let me say you do not need to know these types of aneurysms, just trying to show you what they all can kind of look like. The 2 types that you need to know are true aneurysms versus false aneurysms. In a true aneurysm, this is going to be caused by pressure. And I want you guys to see in a true aneurysm, you see how both sides of the vessel wall blow out? And kind of think of like a balloon. You blow into a balloon, the whole thing is going to inflate. Okay, so I'm going to say all walls distended. Okay. You can see a saccular, but we're not going to focus on that one. In a false aneurysm, this is caused by damage to the vessel. Caused by damage to the vessel. Okay, so basically the issue is I have a tear right there. I tear my blood vessel. If I tear my blood vessel, I have to make a blood clot. I have to make a blood clot to seal that tear. Okay. If I take away that blood vessel, or if I take away that blood clot, what's going to happen? I'm going to keep bleeding out. That's not good. So what ends up happening is I heal around that blood clot. Now I can remove that blood clot, but because I healed around it, it looks like an aneurysm. It looks like an aneurysm. So let me say caused by damage to a vessel. This is healing around a blood clot. Okay. Both of them in the middle, let me say, both create points of weakness. Okay. So think about like a balloon. You have a balloon that's not inflated and a balloon that's uncomfortably full. Which one's more likely to pop? The more you've stretched it, the more likely it's to rupture. Both a true aneurysm and a false aneurysm, if your blood vessel is going to break, it's going to be at that aneurysm. Okay. This is kind of an interesting one. You don't need to take notes on this one here. I'm just bringing it up because I know it happens in MedSearch 1. A dissecting aneurysm, you have a tear, but you bleed into the layers of the blood vessel. So you're bleeding, but you're not bleeding out. It's kind of weird. So here, let's do pink. This is a very distended blood vessel. Anybody identify what blood vessel this is?
Oh, they are.
There's your heart, there's your kidneys, this is the aorta. Okay. Notice this person has 2 giant tears. If you have a giant tear in your aorta, how How much blood are you gonna lose?
A lot.
All of it, very quickly. This person probably died within a couple of minutes. Okay. So when we say aneurysms, people typically think that they happen in the brain. In fact, that's not true. Most aneurysms happen at the aorta. Most aneurysms happen at the aorta. Okay. Causes: atherosclerosis, hypertension. Again, the main common idea here is this increase in pressure. Increase in pressure. Okay, and I guess infection of the vessel wall. That's the third one. That's your inflammation. So symptoms. Typically, aneurysms are asymptomatic. What does that mean? There's no signs, there's no symptoms. Okay. Typically, they're asymptomatic. If you express symptoms, you're considered a lucky one, because now you know to go get medical attention. Dysphagia. What does dysphagia mean? Difficulty eating, difficulty swallowing. So say difficulty swallowing. Why? Why would I have difficulty swallowing with an aortic aneurysm? If we take a look, here's your heart, yeah? Your esophagus is right in line there. If your aneurysm is descending out, it's going to be pushing on the esophagus. You can't get food through. Difficulty swallowing. It can get so bad that a person can experience dyspnea. What is dyspnea? Uncomfortable or difficulty breathing. Okay, so it's pushing on your esophagus and now pushing on your trachea. Now this slide right here, you don't need to write anything down on this one. If you're curious, the abdominal aorta, that is the most common aortic aneurysm, if you're curious. All right. Blood pressure is cardiac output times peripheral resistance. You guys have seen this equation, yes? Cardiac output is the product of what two variables? Cardiac output equals
Heart rate.
and yep, you guys got it. Boom. Okay, so in exercise, what should happen to blood pressure? It should go up. Why? According to which variable would blood pressure increase?
Heart rate.
Heart rate, I agree. So let me say blood pressure secondary to increase in heart rate. Okay. In atherosclerosis, we will elaborate on athero a little bit more. This is a narrowing. Actually, let me change that to blue. This is a narrowing of the vessel. Which variable is going to be directly changed by atherosclerosis? Peripheral resistance. How? Will peripheral resistance be increased or decreased if my vessel narrows? It will increase. Therefore, my question to you, with atherosclerosis, what effect does that have on blood pressure? If peripheral resistance is going up, right? Blood pressure should increase as well. You guys kind of see how that works? If you increase one side, the other side will increase. If you decrease the other one side, the other side will decrease. Okay. Anaphylaxis, we keep talking about it. Okay, what will anaphylaxis do to peripheral resistance? Why? So your peripheral resistance will decrease because you're vasodilating, because of that histamine. Therefore, during anaphylaxis, what happens to blood pressure? Should take. Following up, how would the body compensate for this decrease in blood pressure? Why increase heart rate and not stroke volume? Stroke volume is based on the size of your heart. Can you change the size of your heart? That's why it's heart rate. That's the only one that we can change. All right. Seeing if you guys got this here. What happens to my blood pressure during a heart attack? Let's say it's a widowmaker. Go to the absolute worst. How far down? 2. Yeah, that's good. That's good. I heard somebody whisper it. What should blood pressure be during a heart attack? 0. 0. Why would we have 0 blood pressure during a heart attack? Yeah, so because sorry, purple. Secondary. What value is 0 in a heart attack? Stroke volume is 0 and heart rate. Nice. Anything multiplied by 0 is? So in a heart attack, the worst kind of heart attack, what should happen to your blood pressure? Do you guys kind of get a better feeling on how to manipulate that? It's qualitative rather than quantitative. Yeah. All right. So let's talk a little bit about blood pressure. Hypertension. I have this. It sucks. Not yet, but it will. Now, when it comes to hypertension, these are the different categories and the different ranges. I don't care. I'm trying to remember if you need to know it for health assessment. I don't think so. But don't quote me on that. I think the BMI ranges were more important than these ranges. I think. Okay. But again, for me, I won't test you on these ranges. So there are different types of hypertension. We're going to start off with primary hypertension. Primary hypertension is also known as essential or idiopathic hypertension. What does idiopathic mean?
We don't know what.
Unknown cause. Unknown cause. So again, I can call this primary hypertension. I can call this essential hypertension. I can call this idiopathic hypertension. 3 names, same thing. This is hypertension due to some unknown cause. It could be genetic. It could be that I'm just programmed to have hypertension. It could be that I eat way too many Big Macs. Who knows? Unknown. This affects 92 to 95% of individuals with hypertension. So of everybody in the world, 92 to 95% of them with hypertension, it's primary. Therefore, which is the most common type of hypertension?
Primary.
Okay. Most common. So I, in fact, have primary hypertension. I don't know if anybody else does. Don't worry, you don't have to tell me. What are my symptoms?
Headaches.
I mean, it's probably with caffeine. It's my caffeine withdrawals that are causing headaches. It's the answer you guys are giving me right now.
Yeah.
It's typically asymptomatic. It's typically asymptomatic. I have primary hypertension. I'm not showing any symptoms. Okay. I'm going to reference this here, but it's called the silent killer. Okay, so that's primary hypertension. Secondary hypertension. If primary was due to unknown reasons, what would secondary mean? There's some sort of known reason. So known cause, known disease. Okay. Renal disease is the most common. You do not need to know that subpoint here. We're going to get into that with exam 5. Basically saying your kidneys don't produce urine. So imagine right now if you stop peeing, you just can't pee anymore. Where does all that water go? Back up to interstitial and bloodstream hypertension. Okay. It could be hormonal. We'll get into those during the final exam. So I'm just going to say X through that. It could be congenital. You don't need to know that. That's like Marfan syndrome. If anyone's familiar with Marfan syndrome, the tendons are weaker in somebody who has Marfan's versus someone who doesn't. So a lot of the times they're double jointed. I'm not double jointed, so I don't know what I'm trying to do with my hands. Okay. Marfan's is their collagen is weaker. That means their aorta is a little bit weaker. And it kind of, you don't need to write this down unless you're interested in peds. Our aortas are cylindrical. Somebody with Marfan's, their aorta becomes conical. So a little bit of blood coming in up top, a little bit of blood coming out. If it's a cone, a little bit of blood coming up top, lots of pressure coming out below. That's what it's talking about with congenital. This person's born that way. Don't need to know it, but if you're curious. All right, you have primary, you have secondary, and you have complicated hypertension. Okay, complicated hypertension, this is almost like a threshold. This is now where we have long-term severe hypertension causing tissue damage. So we have crossed a threshold. I have primary hypertension. What are my symptoms? None. As soon as I start showing symptoms, my primary hypertension is now complicated hypertension. Whenever you see the term complicated in medicine, complicated means damage. Okay. Whenever you see complicated in medicine, it means damage. So here, now I'm seeing damage. We can see effects in the heart, the brain, the vasculature, kidneys, and eyes. Yes, you need to know all 5. One thing that might help you out here, this is actually from a previous student. I kinda heart Buena Vista. I kinda heart Buena Vista. Buena Vista is gorgeous, by the way, if you haven't got a chance to see it. Yeah. Translates to the eye because, hey, it can damage your eyes. Kinda damage your kidneys. Heart is heart. Buena is your brain. Vista is talking about the vessels. Out of all the different places in the body, these are the top 5 that are most likely to be damaged by hypertension. You need to know these because it would make for a great select all question. Okay. The type of damage we see is called end organ damage, or EOD. End organ damage. That means we're going to be damaging the organs at the end of the capillary beds. Okay, end organ damage. Okay, we're getting into a couple of examples of end organ damage, but again, this is pretty serious. Okay, you can have primary or secondary hypertension, but as soon as you start showing damage, you've crossed that threshold into complicated hypertension. Okay, so what we kind of mentioned, hypertension is often asymptomatic until this damage occurs. So let's kind of take a look at one of these examples of end organ damage. This first picture here, this is your heart. I'm assuming that you guys are healthy, you guys are young. That's what your heart looks like. Okay. Right here, this space, that's the space of the left ventricle. What do you guys notice between Picture A and picture B. In picture B, this is me right now. This is somebody with hypertension. Okay, what do you guys notice? What happened to my ventricle? Smaller, absolutely, it got smaller. Okay. The red stuff represents the muscle. So if I have hypertension, does my heart have to work harder or is its job easier? If I have hypertension, my heart has to work harder. Therefore, I need more muscle. That's why my septum gets smaller. Okay. Let's equate this to health assessment here. Typical heart rate for a person, what's the range? 50 to 100 is what Lindsay goes with, right? If it's above 100, what does that indicate? If my resting heart rate is like 110. Here's work and tachycardia. That indicates hypertension. People with hypertension have higher heart rates. Why? Take a look at blood pressure equals heart rate times the stroke volume multiplied by peripheral resistance. In situation B, what happened to my stroke volume? So this is when we finally are changing stroke volume. Notice it's taking years for my heart to look like this. So in situation B, I finally decrease stroke volume. If I decrease stroke volume, what do I have to do to try to maintain blood pressure? I increase heart rate. That's why I have an elevated heart rate at resting. Makes sense though. I mean, like you got this little pocket. This thing has to work a lot more to move more blood. Yeah. Okay. Okay, what's the problem with this thing? Dude, my heart's huge. It's a lot of muscle. In order to maintain muscle, you need oxygen, you need blood. Agreed? If this is the size of my septum and it's ejecting blood, am I moving more or less blood at the end of the day? I'm moving less blood at the end of the day. Therefore, if I'm moving less blood, I'm moving less oxygen, less nutrients. What's going to happen to the muscle that I can't feed? That's going to atrophy. That's where we go to here. Picture C. So here is now when I've crossed that threshold. This is now when we are in end organ damage. Notice my muscle atrophies. I'm just saying muscle atrophy. Holy cow. Look at the size of my septum. Ah, suck it. I can move so much blood. Can I though? No. Why not? I don't have enough muscle. This is like biting off more than you can chew. My heart's going to suck in all of this blood. And if there's not enough muscle to eject that blood, what's going to happen to this? It's just going to stay there. My heart's going to try to contract, but it can't get that blood out. What's happening? My heart can't get blood out. My heart is a pump, and if it's failing to pump, I'm in heart failure. Heart's going to fill, but it can't eject. Heart failure is end organ damage. You guys see how that works? So, oh geez. If I was here and now I'm here, if I get my blood pressure in check, if I stop doing 7 cups of coffee and I don't know, 12 Big Macs a week, could I go back?
Yeah.
I still can, because remember, hypertrophy is reversible. If I actually take care of myself, I could go back here. Let's say I don't. I stay here, and now I progress to this part. Can I go back? So what I'm getting at is end organ damage. The last thing that I'm going to add here is irreversible. As soon as we start seeing damage, there is no going back. So once we start seeing the eyes become affected, once we start seeing the kidneys, the heart, the brain, the vessels, you can't make an aneurysm be a not aneurysm. Okay. Side note here. What caused my heart to reshape? What caused my heart to get bigger and then also smaller? What got me into the trouble in the first place? Hypertension. So what I want to add here, pressure. Let me say sustained pressure, sorry. Sustained pressure is the number one factor in cardiac remodeling. Sustained pressure is the number one factor in cardiac remodeling. So if you want to change your heart, you do it through pressure. Okay. So hypertension got me here, right? So would somebody's heart look like this if they exercise? They're feeling hypertension. Difference is with exercise, it's not sustained. It's not 24/7. Make sense? All right, so we had primary hypertension, secondary hypertension, complicated hypertension, and now malignant hypertension. Okay, so whenever we add malignant to something that's already bad, this is like super bad. Okay, also known as a hypertensive crisis. Why? Your diastolic pressure is anywhere greater than 140. What's normal diastolic pressure? 80 or less. So remember I was kind of joking about your blood pressure being twice as high as it should be? That's malignant hypertension. Basically, if your blood pressure is stupid high. You can quote me on that. Stupid high. What's the problem with stupid high blood pressure? Stroke, heart attack. What else? And organ damage. So the stroke can affect your brain. Yeah. Heart attack. This can shut down your kidneys, make you go blind, cause an aneurysm. That's why we say these 5 here, most likely. Okay. I'm not going to get into the difference between emergency versus urgency. Hey, your blood pressure is super high. There's going to be problems. I don't care what we call it. Okay. All right, and the opposite, hypotension. We kind of already talked about it, so nothing too crazy there. Just in terms of orthostatic hypotension, you change your position, that drops your blood pressure. Again, that was the simple reflex with the baroreceptors. You stand up, your baroreceptors stretch out, they send a signal to the spinal cord says strict, keeps the blood back up. All right, so that's the first part there.
Go back to the last slide while we do our break, sorry.
Actually, I'm going to go to a different slide while we go on our break. We're not quite going on break yet, but we will. This slide?
Yes, sorry.
Yeah, you're good. You're good.
Okay.
Yeah, I know it says break time, but hang tight with me, guys. There's a reason why. There's a diagram I kind of want to show you guys before we get into break. So now we're going to be talking about vascular disorders. Before we were talking about just kind of blood pressure in general. Now we're talking about diseases of the blood vessels. A couple of abbreviations, therefore a couple of definitions. PVD, peripheral vascular disease. Okay, this is kind of like the big umbrella that everything's going to fall under. And by any means, you can use these abbreviations on your exam. You don't have to write out the full thing. Okay. PAD, peripheral arterial, yeah. Arterial disease. You guys can see how that's a type of vascular disease. Okay. Arteriosclerosis. Arterio. Actually, let me back up here. This sclerosis Sclerosis means thickening and hardening the arteria of your blood vessels. So arteriosclerosis, your blood vessels are becoming thicker and they're becoming harder. So what's the difference between atherosclerosis and arteriosclerosis? Athero, actually, let me start with sclerosis. Sclerosis is still thickening and hardening. Okay. Athero is fatty plaque. Okay. So both of these are talking about thickening and hardening of your blood vessels. Arterial, it can be anything that is thickening and hardening your blood vessels. It could be calcium, it could be cancer, it could be collagen, it could be scar tissue, it could be dead cells. Atherosclerosis, thickening and hardening, specifically due to fat. So if someone asks you what's the difference between these two, athero is a type of arterial. Arterial can be anything. Athero is specifically fat. Okay. CAD, coronary artery or arterial disease. Seems like a simple question, but students forget all the time. CAD affects which organ? Coronary, the heart. Okay, this is going to affect the heart. And then CVD, be careful here. Undergraduate, a lot of people learn this as cardiovascular disease. Not the case here. Okay, CVD, cerebral vascular disease. Therefore, CVD affects which organ? The brain. Very good. Okay. So just heads up, CVD does not mean cardiovascular disease in this class. Now, the reason why I wanted to get here, you do not have to memorize this, but if you're a visual person, you need to see how things are organized. This will kind of help you out. Okay. You don't need to memorize it, but just to kind of help you visualize what's about to happen. PVD sits at the very top. Okay. One of the types of PVD we will talk about is Buerger's. Not burgers, but Buerger's. Look, burgers right now. Raynaud's is another type of PVD we'll talk about. Okay. Another type of PVD we'll talk about, arteriosclerosis. Okay. What was the specific type of arteriosclerosis? Athero. Okay. So I abbreviate arteriosclerosis as just arterial and athero as atherosclerosis. Okay. Now flipping it, atherosclerosis sets somebody up for 3 different diseases. It can affect their heart and cause coronary artery disease. It can affect their brain, cause cerebral vascular disease. Or it can affect anywhere else in the body, PAD, peripheral arterial disease. Okay. So if this affects my heart, what does this set me up for? If I have fat plaques in my heart. Yep. I'm going to say specifically, it's going to set me up for an MI, heart attack, in myocardial infarction. Okay. And let's just say I get these fat plaques or maybe these blood clots in my brain. What event does that set me up for? CVA. Okay, so what I'm getting at is down here, these are events. Up here, these are the diseases. Okay, if it affects somewhere else in my body, it just kind of depends on where it goes. There's no specific event associated with that. Cool. So that's what I wanted to kind of leave on when we go on break. I'll leave this up here. Yes, cool. If we pick up in like 9 minutes, so 9:50. We need about 9:50. Actually, did you go back to these slides, by the way?
Oh, no, I'm okay, thank you, I just needed that one last little, I was like writing like crazy.
Yeah.
Do you have a chance, how about block, to plug like a USB charger into it?
For
It just, I have my like actual charger, I just thought I had a block in my backpack. And
I have. This is to charge your iPad.
yeah, sorry.
No, you're fine. You got a cable, right?
Yep, I have everything,
So this is just a power bank, but it has a stupid amount of outlet.
thank you so much, sorry.
You're good. That's why I bring it. Yeah, feel free to drain the thing because I can just charge it, no problem.
Thank you very much.
Is that going? Is it good?
It's going, thank you.
Almost missed the chair. That was good. Getting there. Thankfully, I was really worried about my breathing. Like, I think that was just the most scary thing was not being able to breathe deeply. The fact now I can actually take a breath really helps. Yeah, I mean, thankfully, I don't know why it rocked me so bad, but yeah, yeah, like I've never been sick for more than like 24 hours. So I don't want it on anybody.
No, definitely not.
So if you guys can get your boosters sooner rather than later, definitely do it.
Yeah, not mine last week.
Nice. You listen. That's good. You're doing good. We're talking about after. Okay. That's good. That's all I got. Yeah.
Go to go on like yes, all of his stuff. It's super quick, so quickly. I got them last minute. I got them. Cash for trade. Oh, that's so awesome. I got it last minute, 'cause I wasn't even going. I have to go or something. Yeah, he was awesome too. Really. Yeah.
I opened it and I was like. I haven't opened the back text ever. It's like I don't think it's morning.
Okay.
Yeah, my favorite. I don't know.
Yeah, it's not as.
What is it? Like,
But yeah, I still don't have like. I'm waiting. I was kind of trying to. I mean, I'll do it, but it's not. I like that.
Yeah, I know. Someone had an ass like and then I was driving by finding it. I don't really, I have features, I just really, yeah, I have birds. And so I had it on John. I had like.
So.
Like that's.
I think it's kind of anything like building that. Also, like, I look at it as when I don't work out with my or my mental health. For sure. And I started using that as well, because yeah, for sure. I was sure, like, what are the free times you have? Like, what are, I look at it, like, what am I willing to sacrifice?
They're hard to.
Sometimes it's schoolwork, but like, you know, like my boyfriend, and he was only gonna get it again, it was like 2 weekends right? And it was our last one, so it was like Saturday and Sunday only. And he just like, but I'm like, I have to go to the gym, like I have to, but I'm gonna go to the gym, you know, sacrifice.
Yeah, stuff. They got, they were.
Or if I toggle down the road, yeah, same time.
So good.
For an hour, even if you would have I mean,
I'll just.
Yeah, right, and I was on the side, I work with people all the time, especially moms.
But I get when we're brown.
Absolutely. Of course. And the cool thing is like, how virtual everything is too. I work with a lot of people.
And actually they have like.
I did, I have.
So it's very much. And now I'm in here, I still need to get my strap, I forgot, but I still, they have.
It's, I totally understand. I love it. I mean, I don't have to worry about it. I've been in those especially I made it after school, really hard to balance. I always say small. My chest. Like you can do it in your car, whether that's whatever you are doing cardio, unless you're doing cardiovascular. So whenever I am doing cardio, it's very rare. Yeah. I'll go on lunch with my dog. Yeah. That's all I'm.
Cool. So, sorry guys, gonna start bringing it back.
We'll talk.
So, bringing it back, we're gonna be talking about issues with the blood vessels, okay? So first up, you have Weger's disease. Again, it looks like burger. If you can spell it, that's fine. It just makes me hungry. I personally like the Latin so much more because it tells you more. So Weger's disease is also known as thromboangiitis obliterans. Thrombo, you guys already know. What does that mean? Clot, blood clot, right? Itis, inflammation. Okay, and then for the gold star, what does obliterans mean? Nice. Obliterans means some sort of obstruction. Some sort of obstruction. So Weger's disease or thromboangiitis obliterans. It's a blood clot with inflammatory factors causing an obstruction. Tells you more than Weger's. So you'll never have to spell it, but I'm just saying I like using thromboangiitis obliterans, so just heads up. So exactly as we were talking about, they are non-atherosclerotic lesions or clots. Non-athero, these are not fatty. These are blood clots with inflammatory factors. Okay, they usually affect the feet and the hands. Okay, so think about these blood clots with these inflammatory factors blocking blood vessels in your hands and your toes. Typically males that are smokers, cool, but these blood clots permanently block and obliterate these arteries. Okay. So again, the name just tells you everything you need. So taking a look at this here, we've got some fluoroscopy pictures. On the left, on the right though, you don't need to draw this. I'm just trying to draw it for effect. Anybody see the problem with this? So if you received a picture of your patient and you haven't met them yet, what would the nurse expect to find upon assessment? Say again? Maybe cyanotic fingers, maybe. Yeah, without any blood flow whatsoever. Ischemia leads to. So I would personally expect necrosis. Okay. Ta-da! So weird correlation here. I don't think this is related. But remember how I told you this usually affects smokers? What three fingers do people typically hold cigarettes with? I don't know if it's correlated or not, but it seems kind of interesting. Yeah, so that's full on necrosis. Therefore, do we just put a Band-Aid on there? It'll get better over time. What's their only course of action? Yep. Okay, so again, these are blood clots with inflammatory factors causing these blockages. Okay. Now, another one is Raynaud's. Now, I will not discern between Raynaud's disease or Raynaud's phenomenon. I'm just going to call it Raynaud's. Just Raynaud's. I'm going to combine it. Okay. So it is a vasospastic disorder. The blood vessels, they close. Okay. It can be triggered by cold or by emotional distress. It's winter, well, it's still fall, but soon there's going to be snow. You wait for it, your hands are going to turn white. Yeah. Yeah. So with Raynaud's, would we expect the same level of necrosis as thromboangiitis obliterans? Why not? It's a short period of time. This vasospasm is reversible. Your hands get cold, they turn white. What do? You warm them up. So that's what I'm saying. You should not see necrosis with Raynaud's. Okay. Emotional distress. Some people with Raynaud's, stress can be the trigger. So take, for example, when we used to do exams on paper, I would be handing out exams. One of my students had Raynaud's. Every time her fingers were wider than the sheet I printed the exam on. Like, she was fine, she passed, but it's just that stress is what triggered it, okay? And if you have Raynaud's, you know you can't just throw your hands in hot water right away. It hurts to cause it to vasodilate out again. So it's a slow process.
I have that.
You got Raynaud's? Yeah. So exactly, you can't just plunge your hands in hot water and like call it good. You have to slowly warm it up. Okay, so just saying Raynaud's, vasospastic, triggered by cold or emotional distress. Typically, you don't see necrosis. Okay, so I'm just gonna say, next through that slide. The student I was mentioning, this is not them, but you can kind of get a pretty good picture of it. Okay. All right, so the third form of PVD was arteriosclerosis. Again, key point here. Thickening and hardening of the vessel walls. The big issue is that they lose elasticity. So your blood vessels are a series of rubber bands that kind of stretch and contract all the way through and push blood to your furthest extremities. If you lose elasticity, you start seeing decreased perfusion to the extremities. You start seeing decreased perfusion to the extremities. So could we see necrosis with arteriosclerosis? Absolutely. Okay, big issue is that smooth muscles and collagen fibers migrate to the tunica intima. Smooth muscle and collagen fibers. So what that kind of looks like. Here is your blood vessel. This is your blood vessel on arteriosclerosis. Okay. Notice right away the walls are much thicker. Remember, this is arterial, not athero. This is not fat. This is anything. Muscle, collagen, dead cells, calcium, etc. Okay. So right away, what jumps out at you? It's so much smaller. Okay. Now, you guys remember the Colebrook equation? Yeah, ish. Okay. This is an abbreviated form. You do not need to know this. This is because I'm a nerd, but I'm just trying to do this to illustrate a point. Okay. The Colebrook equation is based on the formula Q. Okay, that's basically the Colebrook equation. Now, if we were to simplify this, okay, it's basically 1 to the power of r to the 4th. So r represents the inner radius. Okay. Again, you do not need to do this. I'm just trying to illustrate a point. Let's say right here, this was 1 inch. Okay. So what would be your pressure if you had 1 to the power of 4? 1 over 1 to the power of 4. It'd still be 1. So in this blood vessel, we would expect 1 psi. Not bad, right? What if we have it? What if it's half an inch? Anybody fancy with the algebra? 2 times 2 times 2 times 2. So that's 4, 8, 16, almost. 16 psi. How is that possible? We went from 1/4 inch to half inch. That's not 2. What I'm getting at here is the biggest determining factor for pressure is your inner radius. Inner radius has greatest effect on pressure. If you change your radius by a little bit, what's going to happen to your pressure? It's going to skyrocket. Not double, not cube, it's to the power of 4. Okay? If you take a look at this blood vessel, would you say it's a fair estimation? to say it's a 1/4 inch. It's a 1/4 of what it used to be, yeah? So if you do this math, 4 times 4 times 4 times 4. (256 psi). To put this into perspective, your car weighs give or take 2.5 tons. Anybody know what psi in your tires are? Like 30. What's going to happen if your blood pressure is 256? It's going to cause that aneurysm. It's going to cause that increase in pressure. You guys get what I'm saying now? Okay. Change your radius a little bit. What happens to pressure? Oh, that's crazy. Okay. So again, just the whole takeaway from this, that inner radius has the greatest effect on pressure. Okay. So now we're getting into atherosclerosis. So talk about sclerosis. That's that thickening and hardening. Cool. New part. Athero is the fatty plaques. Okay. So as we mentioned, athero can cause 3 diseases: CAD, CVD, and PAD. Of those 3 diseases, so let me back up here. Atherosclerosis. If you get atherosclerosis, it can affect your heart, your brain, or anywhere else in your body. It is most likely going to affect your heart. If somebody gets atherosclerosis, it will most likely affect their heart. Okay, that's the leading cause of CAD, coronary artery disease, leading to MI or stroke. Okay. Anybody from California? I miss it now. It's the novelty because it's just not here. Yeah. In Colorado Springs, in Aurora,
No, in Lakewood.
in Lakewood.
And there's one in
Well, screw you guys. I live further up north. Okay? I ain't waiting in my car for 4 hours. It's ridiculous. So how does a person develop atherosclerosis? Okay. Take note here. Empty slide with 7 steps. Huh. So this is the last slide before last lecture before an exam. Huh. All right, so how does a person get athero? First step, endothelial damage. Endothelial damage. That's the trigger, okay? This is the trigger to begin athero. So basically, you just damage your blood vessel, or you have inflammation that causes the layers to kind of separate. Okay. Next up, you have LDL penetration, and that leads to OLDLs. Okay, a little bit of review here. You don't need to write this down, just recapping. HDLs versus LDLs. HDLs are known as the good fats, LDLs are known as the bad fats. Agreed? Why? So again, you don't need to write this down. This is just a little bit of refresher. HDLs, high density lipoproteins. What they do is they take fat from your organs, bring it to your liver so you can poop it out. LDLs, other way around. They take fat from your cells, your adipose cells, your liver, and then bring it to your organs. Sounds terrible. It's actually, you need LDLs. Why? Think about your heart. Your heart's a muscle, yes? When's the last time your heart had a cramp? When's the last time your heart needed a break? It doesn't, because it runs only on fats. Only runs on fats. How do the fats get there? LDLs. Problem is, I eat too many In-N-Out burgers. More fat than I can handle builds up around my mouth. Okay, so the issue is LDLs. They're going to get underneath the blood vessel and then oxidize. So So I'm going to say LDLs get under the endothelium and oxidize. That's why they go from LDLs to oxidized LDLs. And I promise there's pictures coming up here that actually kind of visually show you guys what's going on here. Okay, oxidized things. The body does not like oxidized substances. Why? Leads to cancer. Just summarizing and kind of really simplifying it. Oxidized things lead to cancer. So that's bad, yes? Who do we send in to kill things that are bad or eat things that are bad? Next step, I'm going to send monocytes / macrophages. Macrophages migrate. Okay, so your macrophage will eat your oxidized LDLs, but they can't break them down. Can't break down. Okay. So your macrophages, I want you to imagine they're eating all of these fat cells. They're eating all of this fat, but they can't break it down. So these cells are just storing fat at this point. That's when they become foam cells. Foam cells. Foam cells are engorged macrophages. The problem is they keep eating and eating and eating. They get so large, they get trapped. Trapped in the vessel wall. Okay, and I promise there's pictures coming up here. Okay. Now the problem with foam cells hanging out there, that really reduces the radius of your blood vessel. If our radius gets smaller in our blood vessel, good or bad? Extremely bad, because it's going to cause the pressure to skyrocket. So we're going to rearrange our foam cells into fatty streaks. Fatty streaks. Rearrange foam cells into fatty streaks to minimize radius lost. To minimize radius lost. Okay, cool. We like the way it looks. Now we're going to turn it into a fibrous plaque. Basically, we're going to tie everything down with collagen. We're going to make it fibrous. We're going to lay collagen on top of it. Finally, the last step with atherosclerosis, my plaque complicates. I have a complicated plaque. Anybody remember, what does complicated mean? I've damaged my plaque. Damage to the plaque. The issue is this is going to trigger coagulation. Okay. 7 steps to atherosclerosis. Okay. So I would probably know the ones in black, but use your own words to describe them. Yeah? Huh. I don't know. Maybe I just don't give you guys anything and just say go. It's another possibility as well. Just depends on how spicy I'm feeling. Okay, so a couple of pictures to kind of help us like incorporate all of this together here to help visualize what's going on. So step one, here's my blood vessel. It's kind of hard to see. I'll zoom in. You guys see that right there? That's your endothelial damage. Oh, God. It's absolutely tiny. It's a tiny little tear, but that's all we need. Okay, so step one, you have some sort of damage, you start tearing that blood vessel there. Uh-oh. Take a little bit of a closer look. You have this tear. These are your LDLs. Okay, they're getting trapped underneath the blood vessel. Here's your tunica intima. They're getting underneath that tunica intima. You guys ever see those commercials for those medications that are supposed to scrape plaque out of your blood vessels? You see like that little fat plaque hanging out here? That's 100% bullshit. Why? Your fat plaque isn't just hanging out of your vessel. It's underneath that first layer. That's why scraping plaque doesn't work. Okay? So LDLs get underneath there, they oxidize. We send in our monocytes, which turn into macrophages. They start eating these oxidized LDLs. Okay, they eat and eat and eat, but they can't break them down. That's when they become foam cells. These are trapped macrophages. We're going to rearrange these macrophages into this fatty streak right here. Okay, the whole idea was to minimize the loss of the radius. Okay. So after I've made my fatty streaks, now I go and start laying down collagen. I make it a fibrous plaque. You guys notice something though? Here was my fatty streak, and now I start laying down collagen. What happens to my inner radius? It gets smaller. And if I decrease my radius, what happens to pressure? You see these cracks right here? This is your complicated plaque. Because I've lost radius, pressure skyrockets and tears that collagen. When we have raw exposed collagen, that triggers a blood clot. Now, if that blood clot stays there, what do we call it? Thrombus. If that blood clot detaches, what do we call it now? Thromboembolus, right? Because it's a blood clot that's moving. Embolus refers to anything. So that is atherosclerosis in a nutshell. Okay, it ends with a giant lump. Yes. Okay. So peripheral arterial disease. So atherosclerosis can happen in your brain, your heart, or the rest of the body. Where is it most likely going to happen? The heart. This is talking about PAD. Anywhere else. So exclusive of the coronary and of the brain. So it's like happening in your arm, your leg, etc. Not likely, but can. Okay, coronary artery disease. This is affecting your heart that narrows or occludes the coronary arteries. Okay, atherosclerosis is the most common cause. So what's the issue if I start having these fatty plaques develop in my coronary arteries? There's a blockage. What happens to blood flow? Ischemia leads to. So what's the big issue if I have these fat plaques? Necrosis. Now, necrosis of the heart has a specific term, which we're going to get to. Okay. So this slide right here, let me say, you do not need to know this slide. I'm not going to ask you. I do want to just talk about dyslipidemia, just as a vocab term. Dyslipidemia. Dys meaning abnormal. Lipid, fat, in the blood. Okay, so talking about normal ratios. In a healthy person, HDLs, should you have high or low? You should have high HDLs. What about LDLs? Should be low. In dyslipidemia, it's abnormal because it's switched. This person has way too many LDLs, not enough HDLs. Okay. Has anybody ever seen somebody's blood with dyslipidemia? It's freaky. You ever see blood chunk up? So there's a good picture. Yeah, that'll work. So just a quick Google search. Their blood comes out looking pretty good. You let it sit. It's white stuff. What's that white stuff? That's lipids, that's fat. Think about butter. Butter is liquid at heated temperatures, your internals. Take butter out, put it on the counter, it solidifies. So yes, somebody with dyslipidemia, they have that much fat in their blood. So the question is, how does the LDLs get underneath that first layer? How do the LDLs penetrate underneath that blood vessel? It's because there's so many. Does it make sense? Okay. All right. So coronary artery disease, we talked about, hey, myocardial ischemia leads to hypoxia, which leads to necrosis. That necrosis is your myocardial infarction, an MI. So a myocardial infarction is where we see necrosis of the heart, either part of the heart or the entire heart. If my heart begins to necrose, reversible or irreversible? Irreversible damage and cell death. Okay. Don't worry about the two subpoints there. Those are talking about abnormal EKGs, so non-stendies and stendies, ST elevated or non-elevated. So that right there is necrosis. Problem, yes? All right, so let's talk about some symptoms somebody might experience. You might see angina. Angina just refers to as chest pain. Okay. Now, the 5-year-old in me, I like saying angina. It's pronounced angina. If you're uncomfortable with saying angina, you can call it angina. That's fine. Pay attention to how Lindsay says it. Just saying. Again, I'm like a 5-year-old child, so any chance I get. So stable angina is predictable. Predictable chest pain. So if I eat 10, I don't know, 2x2s, that sounds nice. If I eat 2 double cheeseburgers, or if I eat 10 double cheeseburgers and that makes my heart hurt, okay, so maybe I try 8. 8, no problem, my heart doesn't hurt. See how it's predictable? As long as I stay below 8, I'm fine. But it also could be with exercise. Maybe my heart rate, if my heart rate doesn't exceed 180, no pain. Okay, but if it goes over 180, pain, therefore that's stable angina. Okay, unstable, therefore, unpredictable. Yeah. Okay, now let's assume, stretch your imaginations for this one. I am healthy, I am vegan, and I like to exercise. Okay, so let's just say I just finished a marathon, I'm feeling great. I go to sit down. My heart starts hurting. Does that make sense? No, it should hurt with activity, not with rest. That's unstable angina. Okay. Prinzmetal angina, this is from a coronary artery spasm. So one of the blood vessels feeding your heart closes. Therefore, how much blood is going to your heart? None. Your heart's going to hurt. It's suffocating. Okay, that's Prin's metal angina. Now, typical test question here. Of these three anginas, which one's the most concerning for a patient? Okay, so can we all agree to rule out stable angina? If it's predictable, you know what to avoid, yes? Okay, with Prin's metal angina, your coronary artery spasms. Your heart's not getting any blood, your heart's hurting. Now, if your heart starts hurting for 5 minutes, 10 minutes, 15 minutes, still hurting, what do? You panic, you call 911, you get yourself to the emergency room, yes? Okay. Unstable angina. Do you ever have those random heart twinges?
Yes. Exactly.
Yeah. Do you go to the ambulance for that?
No.
Do you know to seek medical attention? Do you have to seek medical attention? You don't know. That's the problem with the unstable is you don't know if you need help or not. Is it just a twinge? Is it just a random spastic event? Or is it something serious? Yeah. So unstable is the most concerning because patients don't know if they need help or not. With Prin's metal, that pain, it's constant, it's going, it's not going to go away until it's resolved. Okay. Now, ischemia, a couple of different types of ischemia. Silent ischemia, asymptomatic. You would never know what's happening. Transient ischemia, this is like a TIA, transient ischemic attack. It's when I had a blood clot hit my brain. I can't talk. I start slurring my words and then my faith group. Go to the hospital, an hour later, I can talk just fine. So this is going to say this temporary CVA symptoms. And then sustained ischemia, exactly as it sounds, unresolving symptoms. Unresolving symptoms. So same question. Of these three ischemias, which one would be most concerning for a patient? The silent ischemia would be the most concerning. Why? You don't know what's happening. You don't know if you have a heart attack. You don't know if you have a stroke because you don't have any symptoms. Most concerning. Okay. Just again, the reason why those two are the most concerning is because you don't know if you need to seek medical attention. You don't know if something's true. So, abnormal EKGs, don't worry about them. Okay, so we got some fat plaques inside of our blood vessel. Can I just go through and scrape it? No, what's the problem with that idea? Why can't I just scrape this out? Damage, and where's the fat? It's in between the layers, right? It's not just hanging out in the blood vessel. So you might go through and have an angioplasty. You take this balloon, you blow it up. It sounds great. Turns out, this procedure has no significant effect on lifespan. Somebody's having a narrowing of their arteries. They have it blown up. Great, grandma gets to live for another 3 years. That's it. Why? Well, it's better than dying now, but it doesn't change lifespan significantly. Why? Still there. What happens to my blood vessel wall? What do we call that? These angioplasties can create aneurysms. Problem, yes? If you do want significant changes in life expectancy, you need to get a stent, i.e. this metal cage. Okay, so these two procedures here, kind of the same thing. You have a tiny plaque, either A, take a balloon, inflate it, pack it down, what we just saw, that was the angioplasty. Or B, you have this tube, you inflate it, it makes this metal cage, we leave the metal cage behind. That keeps the blood vessel open. Both cases, what do you guys see? It's still creating aneurysm. So risks versus benefit, right? The other thing they don't tell you about these stents, these are nice. These are made of metal, made of titanium typically. They're usually coated to prevent your immune system from attacking it. Sounds great. The body doesn't like foreign objects. So what's it going to do? The body's going to start coating this in scar tissue. So if I start coating this in scar tissue, what happens to my inner diameter? With these stents, that's why you need to have them revised every 5-10 years. Okay. This is actually really cool. Sorry, I meant to have all of these pulled up for you guys. So as I had mentioned, most of these stents are actually made of titanium. Oh, come on. If it doesn't work, I'm sorry, guys. I'll try to get it to work. Great question. I haven't heard of a case. It could happen, but I don't think so. Just because it makes a pocket. It's kind of like trying to. So imagine like you have a Hummer and you build a garage around the Hummer, but then the garage door is not big enough. The Hummer's not going to go anywhere, right? So typically they don't become dislodged. Oh, come on. Well, that's not really sure. Okay, maybe I'll try to get it to show up during the next break. But there's new technologies on the horizon. I think the University of Michigan in 2020, they just released a paper and a patent for a new type of stent that dissolves in 7 years.
Wow.
It dissolves slowly over time in 7 years. So therefore, you never need a revision. You don't have to worry about the immune system attacking it. You don't need to worry about scar tissue buildup. Medicine's changing all the time. It's crazy. Okay. So if you do have a coronary artery blockage, we need to bypass it. Coronary artery bypass graft. Basically, we take a vein from your leg, from a donor, from an animal, or completely artificial. We graft that vein up to the aorta, past the blockage, so it goes right around that blockage there. We leave the blockage intact. Okay. So if you have one bypass, single, double, triple, high score is the quadruple. Coronary artery bypass is kind of a mouthful to say. That's why we call it cabbage. So you can have like a single, double, triple, quadruple cabbage. That's why there's a picture of a cabbage. Yeah. Eat more cabbage. Okay. So let's see. Is class already over? No, that clock. I was like, fuck, that's not like an hour. All right, let's take a little break here because we're getting into disorders of the heart now. Let's go like 10 minutes, so 10:40. We'll pick back up again, okay? That clock is going to be definitely. Yeah, so 10:40. This is why you don't test it. Man, okay. It's probably because that link's dead now. Hmm. Also in Colombia, that these women, they have this ancestral knowledge of basket weaving, but that's all they know how to. That's all they know how to do, and they don't want to get into drugs like selling cocaine. So the surgeon actually commissions these women to hand make stents by hand out of this titanium wire, like a single wire to make a stent. And the crazy thing is, their abilities have not yet, or machines cannot keep up with them. Does that make sense? They haven't made machines capable of weaving these stents as well as these women do. So this surgeon basically helped turn around this entire economical situation of this village by having these stents made by these people. So it was cool.
Reverse to be like the myopic coronary artery disease. Can it be reversed if you get your HDLs higher and your LDLs lower?
Unfortunately, no. As soon as we start developing these plaques don't go away. So the best thing we can do is once you start developing these plaques is to stop the growth of these plaques.
Okay.
So unfortunately, no, coronary artery disease does not go away. That's an example of the end organ damage. Mhm.
So I have compartments that when we talked about that.
Uh-huh.
And compression makes my legs worse. What do I do? I can't wear compression socks. I'm just gonna be screwed and have to get my legs cut off or what?
No. I mean, like, go to the nurse's station and kick back up, put your feet on the table, and say, I have a medical condition. But basically, like, the best thing to do is just make sure that the blood isn't pooling in your legs, so constantly moving really does help. But also, like, elevating your legs every now and then. Like, you kind of see, I kind of cheat. I sit and then I kick my feet up. And whenever people say, like, oh, that's so rude. It's a medical condition, right? Don't judge me. But yeah, as long as you like elevate your legs every now and then, you'll be fine.
No, it's both my legs and my arms, but my legs, I had to get surgery on my arms and my exercise and do so it's like a building of pressure in the compartments of my muscles. So I couldn't feel coming in college. Obviously, that's a long distance sport, so my legs got real messed up. And I got a bilateral fasciotomy, so they just basically went into my legs, slice them open so they didn't. But it did work. So it's better now, though. Now that I've been driving to undergrad for 4 years, so it's definitely had some time to relax a bit. But
That's basically how I explain it to them. Because we'll talk about compartment syndrome and fasciotomies in the last lecture. It's one of my favorite lectures, but it's more of a primer for foundation than the search one. So.
Safe to see the damage though to diagnose it as CAD, right?
Usually, yeah, what they'll do is they'll do fluoroscopy and they're gonna see like, okay, so you had, for lack of better words, you had like a thumb sized blood vessel going into your heart, and then a pinky coming out. you know that something's restricting blood flow at that junction. So it's actually pretty easy to diagnose and find out.
So it's not right when your blood work for the first time comes back that your LDLs are high.
No, oh god, no.
I'm
No.
thinking,
I know, this class can turn you into a little bit of a hypochondriac. I guess students sometimes are like, I need you to take a look at my lab values and tell me if I'm dying. You're not dying, you're fine.
That's reversible lab values.
Yeah, and like LDLs, it's just the unfortunate part is we have too much of a diet, right? Like I said, they're not necessarily a bad thing. The problem is that we get too much. So learning how to live with evil isn't the same thing as being evil. From a medical standpoint, don't take that further from that. Because I'm pretty sure like Winston Churchill would have words. Yeah, because like take for example, my parents, they have pre-diabetes, they have elevated LDLs, elevated cholesterol, but they're vegan and they're Buddhist. Like they don't eat anything with fat in it. My mom she's the type of person where, oh, I've had a stock of celery, I'm good. I'll full. What? So again, the lab values are everything.
Okay.
Yeah. So that's the tricky part about it.
Just like touching on things that like lab values. Like, my mom's big, always been big. Her cholesterol and A1C is better than mine. Isn't that crazy how it doesn't make sense? No.
When you hear those stories of like 9-year-old Ethel who's been chain smoking for the last 66 years. No
They're
problem.
97.
Yeah. And then you ask them, what's the secret to long life? Oh, I drink 3 Dr. Peppers a day. Okay. So.
I had a patient once, she drank so much Pepsi that once we like limited her Pepsi because we're like, this is insane, like when her lab values were high, it made her lab values way worse because her body had like adapted to however many she would drink like almost an entire 12-pack of Pepsi a day. And we're like, oh, you can have 4. And her lab values like reading down. They're like, well, you have Pepsi.
Yeah, it's kind of interesting, the physiological dependency. I don't know if is anyone from like New York or familiar with New York, Appalachian area? I don't know what it's called, but they call it Mountain Dew now. It's like this very remote mining town in the Appalachian Mountains where like there's not enough fresh water there, but there's plenty of Mountain Dew. So like it's crazy. Like you'll hear these stories, but so what?
There's a bunch of like so there's like, oh, there's just this one.
That's true. That's true. It's kind of like Boulder and Medellin.
I was just not like myself.
It's kind of like Boulder and Medellin. Like you have the 2 great dichotomies of like the super wealthy and then the super not. Like people go to Netherlands for 2 reasons. Either they want to never be found, or they don't want anyone to find them. If you've ever been up that way.
There's no sense. That's such a weird.
Yeah, a lot of my mentors, my professors used to live up there. They still do.
And see you.
Yeah. So it's like, nah, man, not me. Bear's always gonna win. I'm good. All right, so I think hopefully we'll be able to finish this up here. Okay, so now we're moving to issues of the heart, starting with the pericardium. So what part of the heart is being affected? Peri, around the outside, so this is the outer layer. What I want you guys to keep in mind, no matter what we're talking about here, all pericardial pathos will decrease cardiac output. So the one thing that they all have in common is that they're going to decrease cardiac output. Okay. That's kind of just the big takeaway part here. So if your pericardium is inflamed, let me actually just blast through this and you'll see why. If your pericardium is inflamed, or your pericardium is full of scar tissue, or you are filled with fluid, so this is pericardial effusion. This fluid here is called tamponade. What's that going to do to your heart's ability to beat? It's going to become harder. Your heart will not fill as much, yes? So preload, what happens to preload? You decrease preload, what happens to cardiac output? That's the takeaway point. I do not care about the individual bits. Need to know decrease cardiac output. Good? Hey, what do you think your cardiac output's going to look like if your heart's covered in inflammation? It's going to go down. All right, so now we're going to disorders of the myocardium. So muscle, middle layer. Again, what do you think these all have in common? If you have some issue with the muscle, decreased cardiac output. So let me say myocardial issues will all decrease cardiac output. Okay, basically I'm saying if your heart is affected negatively, you're gonna have a decrease in cardiac output. Okay. Thankfully, we've actually kind of talked about these here. So actually, I'm just gonna roll into the next slide because the next slide has pictures that we can just, okay. So taking a look, this is your heart, okay. When high blood pressure sets in, remember how we talked about your heart getting more muscle, but your ventricle, that septum getting smaller, okay? So in or in situation C, we see decreased stroke volume. What effect does that have on cardiac output? Decreases cardiac output, yeah. Okay. Now, it gets really bad, your heart starts atrophying and blows out. So you have increased stroke volume. Sounds great. Can your heart contract though? So what happens to heart rate in situation C? Sorry, what happens to heart rate in situation B? It fills, but can it beat as well? So decrease heart rate. What effect does that have on cardiac output? You guys see what I'm saying? All of them lead to a decrease in cardiac output. Okay. The last one here, D, looks pretty similar to A, right? The issue with D, this is not muscle. This is collagen. If half of your heart is scar tissue, what happens to the ability to beat? Yeah, decreased contractility, decreased cardiac output. Again, what do they all have in common? Sound good? Okay, valvular dysfunctions. A couple of keywords here that will actually show up not only on exam 3, but exam 4, okay? Stenosis. Whenever you see stenosis, that means narrow. Valvular stenosis means the valve is getting narrow. So let's kind of think about this. Let's go, let's say the example will be tricuspid stenosis. Tricuspid stenosis. So your tricuspid is becoming narrow. Which side does the tricuspid sit?
Right.
Right side. So I'm going to draw it kind of like in this curve here. Okay, so it's super, super narrow. Does that make it easier or harder for your right atria? Yeah, aorta. If it's super narrow here, this chamber has to work harder. Agreed? What happens to muscle that when it works harder? What cardiac morphology would the nurse expect? How would the heart change in relation to tricuspid stenosis? Which chamber should get bigger? So this would lead to right atrial hypertrophy. You kind of see what I was hinting at. Hey, you should know how blood flows forward and backwards. Because if I change this, what if I said pulmonic semilunar valve stenosis? How would that change the morphology? It would be the right ventricle that is hypertrophy. Make sense? Okay. Regurgitation is backflow. Valvular regurgitation is backflow, i.e. the valve is now, the valve can't close, it's broken, it's bent backwards. Okay, so the example here, let's say aortic semilunar valve prolapse. So prolapse means backwards. Backwards. So when something has prolapse, it's bent backwards. You guys ever hear of a prolapsed penis? It's when the butthole's on the outside. It's backwards. Yeah. Okay. So aortic semilunar valve prolapse. First off, what side is that? It's on the left side. Okay. The issue is that this valve is now bent backwards. Yes. So, question for you. The patient has an aortic semilunar valve prolapse. Which chamber will the heart regurgitate blood into? It'll be the left ventricle regurgitation. Okay. If I change this to the mitral valve, if we have a mitral valve prolapse, which chamber would receive the regurgitation? The left atrium. Okay, forward and backwards, see? So just get used to drawing the heart and kind of remembering that blood flow. You're going to be seeing it a lot. So mitral valve prolapse syndrome, i.e. the mitral valve is the most common valve to prolapse. If a valve is going to be bent, if a valve is going to be broken, it's most likely the mitral valve. Why? First off, where is your mitral valve? It's right there, agreed? Now, you have two stages to your heart. What are the two cardiac stages? So let's say diastole. In diastole, is your mitral valve open or closed? Should be open. Because during diastole, we are filling the ventricles. Agreed? Okay, therefore, during systole, your mitral valve should be closed. Okay. So let's say I have hypertension. Okay, let's say my blood pressure, well, it's supposed to be 120. So let's say I have, I don't know, 180. I got 180 millimeters pushing back on my heart. Okay. Most students, they typically think it's the aortic semilunar valve that's going to prolapse. Because, hey, high blood pressure, I have 180 millimeters in my body pushing against this valve. It's a lot, yeah? If my heart wants to get blood out, do I have to be with more, do I have to generate more or less pressure? If I want to get blood out of my heart into my body, do I need to beat with more or less than 100? More. I have 180 pushing on one side. I need to generate more. Like what? 200? Which valve experiences the greatest amount of pressure? Mitral valve during systole. So what I'm getting at is, again, most common valve people think, oh, it's like hypertension, you're pushing on that aortic semilunar, that's the one that's going to give out. Not true, because your aortic semilunar is open during systole. Okay, so why is the mitral valve most likely to prolapse? Mitral valve experiences the greatest pressure during systole. Yeah, see what I'm trying to say there? Okay, during systole, that semilunar valve is open, but it's that mitral valve that's going to get that 200. Okay. So, what do you see? Upside down jellyfish right there. Or right-sided jellyfish, I guess. Give you a hint, it's prolapsed. How do you know if it's the mitral versus the tricuspid? Two flaps?
Yeah.
It's on the left side, which depends on which side of the heart, right? Look at all that muscle. Which ventricle has the most muscle, left or right? That's how you know it's the mitral valve. All right. Acute rheumatic heart disease. This is a weird one. I'm going to straight up just tell you what the quiz question is going to be. I just don't like it. Acute rheumatic heart disease is basically when the immune system targets and attacks the heart. Okay, so kind of walking you through this here, straight up telling you, like, there's a quiz question about, like, what is it called when the immune system attacks the heart? Rheumatic heart disease. Okay, what happens is you get strep. You guys have heard of strep, streptococcus, some sort of throat issue. Agreed? Normally it stays in the throat, no problem. 3% of those, you don't need to know the stats. 3% of those with untreated strep will get rheumatic fever, and of that 10% rheumatic heart disease, i.e. 0.3% of people who get sore throat from strep end up with an autoimmune disorder. Yeah, it sucks. Okay, you're gonna hate strep by the end of this because strep causes so many problems.
Bacterial strep, right?
Correct, correct, yeah. It's that B hemolytic, which means the type of strep that causes you to break down. Endocarditis, inflammation of what? The inside of the heart, usually bacterial. How the hell does bacteria get inside of your heart? Yeah, exactly. You guys are all right. The bacteria was already in the blood. It's not like the bacteria crawled through my skin, my muscle, my lungs, my chest cavity, and got into my heart, right? Usually it's because the bacteria is in the blood. What do we call it when bacteria is in the blood? Sepsis. Okay, so endocarditis is typically caused by sepsis. Yeah, you don't need to write this one down, but this is kind of weird. The bacterial infection inside your heart causes these little cauliflowers to grow on the valves. This prevents the valves from closing properly. Okay, dysrhythmias, pretty straightforward. Dys, abnormal, rhythms, disturbance of the heart rhythm. Cool. Okay, so pretty straightforward here. Let's take care of the easy ones. Tachycardia means what? Increased heart rate. Bradycardia, decreased. Okay, we're going to come back to flutter and fibrillation, I promise. Premature ventricular contractions. So that means your ventricles are contracting too early. Therefore, is that bad ejection or bad filling? So again, they're contracting too early. Bad ejection. Okay, they're contracting too early, so their ejection is like 50%. Okay, therefore, if you see premature atrial contractions, your atria are contracting too early, does that lead to bad ejection or bad filling? Bad filling. Okay, PVCs and PACs, this is usually some sort of electrical problem. Maybe the SA node's in whack, maybe there's some sort of block, etc. Okay. Asystole. A means not or without. Does anybody remember systole? Contractions. So here, there's no electrical activity. Okay, this is the flat line. What do you do?
You can't shock it.
Yeah, shocking is not really going to do anything. So when we shock something, the idea there is to short circuit it, to reset it. Okay, really the only thing you have left is like slap Jim around, remind him he's like 3 days away from retirement, and then do chest compressions. Okay, again, because the heart's not contracting, the idea of chest compressions is to get it to pump, to move blood. Okay, so yeah, no shocky, sorry. You can shocky here, but not here. Okay, flutter. This is going to be, let's scrap this one. This is when the atria contract too early. Atria contract too early. Similar to what? So flutter is another way to describe the PAC. That's what I'm trying to get at. Okay, so your heart rate should be kind of like, you know, an even tempo. Bump, 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 bump. Flutters, bump, 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 bump. Okay, the atria contracting too early. So therefore, bad filling, less blood coming out. Fibrillation, the one you're going to hear is shaking in place. Basically, the issue here is there is no coordination. No coordination of the chambers. Everybody's doing their own thing. The ventricles are contracting before they're filled. The atria are contracting before they even have blood. The heart's just shaking in place. So, test question would be something like, what's worse, flutter or fibrillation? Why? Think about cardiac output. You're onto something. Think about cardiac output. With a flutter, increase or decrease of cardiac output? It decreases, I agree. Now, if your heart is shaking in place, increase, decrease? Decrease more or less than a flutter? More. So with a fibrillation, you have minimal cardiac output. That's why fibrillation is considered worst. Another situation in which you can shock them. Okay. So fibrillation force, just because the heart's shaking in place, no blood's going in. Heart failure. Awesome. Keep it simple. What's your heart's main job? To pump, to eject blood. So heart failure therefore means your heart is, inadequate perfusion. Your heart's not pumping. There are two types of failure that you guys need to be aware of. It's not that hard, I promise. Left-sided heart failure versus right-sided heart failure. Did you guys already talk about this in health assessment? Okay. Hey, guess what's happening in health assessment soon? Okay. Now, in left-sided heart failure, Lindsay's going to tell you this. The way to remember this, where do you look for symptoms? Left side, you look at the lungs. Right side, therefore, you look at symptoms at the body. Why? Well, let me explain it. Okay. So taking a look at left-sided heart failure, 2 ways to fail. You don't need to get into all these subpoints here, but just keeping it simple. Systolic left-sided heart failure. What is your left side failing to do? Failing to eject. Absolutely. Therefore, diastolic, failing to failing to fill. That's what you need to worry about. You don't need to worry about all the little supplements here. Okay. So I'm going to scroll back up so I can kind of draw this here with more room. Here's your heart. Goes to your lungs. Okay. In left-sided heart failure, the left side completely shuts down. Whether it be not filling, not contracting, the left side shuts down, yes? Where does blood begin to back up? Kind of think of it like a traffic jam. This is where you have an accident. Does traffic build up before the accident or after the accident? So it's going to start backing up to. This is why I was talking about, hey, you should know the blood forward and backwards. It's going to back up to the lungs. So why do you look for symptoms in the lungs with left-sided? Because the lungs are going to start filling with fluid. Okay, again, the left side is frozen. It's not taking any more blood. The right side is still pumping to the lungs. So let's just say my lungs are now filled with fluid. What's going to happen now? Where's blood going to back up after my lungs fill with fluid? So, left-sided heart failure, can that lead to right-sided heart failure? Okay, that's the takeaway here. Left-sided can lead to right-sided heart failure. Okay, my recommendation, I know it's a little small, draw it out on a bigger piece of paper, trace through that circulation. Okay, left-sided failure can lead to right-sided failure. This is what we were just talking about. Blood backs up in the pulmonary circulation. That's why you check out the lungs with the left side. Okay. Versus right-sided heart failure. Right-sided heart failure mostly caused by something like COPD or ARDS. That's weird. COPD and ARDS, that's a respiratory disorder. Those are respiratory pathos. How can a respiratory patho cause heart failure? Close. So you have a pulmonary patho. If you have a pulmonary pathology, what happens to your ability to breathe? Decrease is causing what kind of state in the body if you have less oxygen? Hypoxia. What does hypoxia go on to cause at the lungs? What is that an important trigger for? Shunting. That's going to cause increase in pulmonary hypertension, blood pressure. Okay, that's weird. Let's draw it out. Okay, so at my lungs, I had some sort of shunting going on. Here is your accident. Here is your accident, right in front of your lungs. Therefore, traffic builds up behind. So blood will start. This is why pulmonary pathology can lead to right-sided heart failure. The pulmonary hypertension causes blood to back up to the right side. That causes right heart failure. And if you're paying attention towards the almost very end of pulmonary path, that's called core pulmonary. That's not spelled correctly. Just heads up. Check it out in your notes. It's at the very end of respiratory patho. Okay. So my right side starts failing because of my lungs. Where does blood back up after my right side fails? Where do I look for symptoms of the right-sided heart failure? Symptoms at the body. What I'm getting at here is, hey, you should probably know your anatomy. Draw out the heart a few times. Draw these arrows. Question. Does right-sided heart failure lead to left-sided heart failure? Okay. If my right side goes down, that causes blood to back up to my body, yes? Your body's a big place, though. Your body's a very big place. So, no. So, very good. Right heart fail, no lead to left heart fail. Okay, now you can memorize this, absolutely. You can memorize that left-sided heart failure leads to right-sided heart failure, and right-sided heart failure does not lead to left-sided heart failure. Or you know your anatomy. Draw it out. Draw these arrows. Okay, especially in health assessment, when you have to start thinking about symptoms and trying to monitor and assess different kinds of symptoms. Okay. So that's what this point here, right-sided heart failure, commonly caused by left. Okay.
So to make sure I thorough understand. The shunting backs up the blood of lungs and you get there and then that back up.
Yep, because then your right side has to work harder. The problem is you keep pumping blood into here, but it's blocked. So it's working harder and harder, that blood's creeping up. Eventually, your right side doesn't have enough muscle to actually get that blood through like your left side does. That's why it fills and it can't eject. All right, high output failure, just skip it. It's a weird one. Shock. So different types of shock here, keeping it pretty simple. Cardiogenic shock. Genic means causing. So if somebody has cardiogenic shock, what's the problem organ? Heart. Heart issue causing shock. Okay, it could be that you have heart failure. It could be a myocardial infarction. It could be right-sided heart failure, left-sided heart failure. It could be some cardiomyopathy. Whatever reason, cardiogenic shock, hey, heart's not beating. Okay? Hypovolemic. Translating that, low volume, emia, low blood volume. Okay. So low blood volume, i.e. somebody got stabbed, they're bleeding out, maybe they just don't have enough blood, etc. Okay. Neurogenic shock, what's the problem, Morgan? Brain issue causing the shock. Okay. So it could be some issue with the area of the brain that controls the vital reflexes, which is, could be an issue with the brainstem. Okay. Anaphylactic shock. What causes anaphylactic shock? The allergy, sure. What's released? Histamine. That causes your vasodilation. That causes your drop in blood pressure. Septic shock. So kind of talking about it, there's a progression. It doesn't just like, boom, you got septic shock. It starts with, it starts with what? Bacteremia. Bacteremia, bacteria in the blood. This is talking about, hey, you have the presence. You have the presence of bacteria. Okay. Bacteremia leads to septicemia. Septicemia. That is the growth of bacteria. Okay. It's one thing to find bacteria in your blood. It's another thing to find bacteria growing. If bacteria is growing in your blood, who's winning, the bacteria or the immune system? See, that's the difference there. Here, maybe the immune system's still in check. Here, this is when the immune system starts losing. Septicemia then leads to sepsis, okay, which leads to severe sepsis, which leads finally to septic, shock. Okay, I'm not going to elaborate too much onto it. You'll get more of it in MedSearch 1, but basically we see organ impairment, due to the bacteria. Okay, so obviously all I'm saying is the further you go, the worse case it is. Okay, with sepsis, your organs start having their functions interfered with, so your heart doesn't pump as well. You saw those vegetations. Your liver doesn't produce all the enzymes it needs to. Severe sepsis, you start seeing pretty much organs beginning to fail. Septic shock, multiple organ failure. Okay. You'll get more into that with MedSearch 1, just understand it's a progression. Okay. So talking about multiple organ failure, that is MODS. MODS, multiple organ dysfunction syndrome. Dysfunction of two or more organ systems. Okay. So MODS is another way to say multiple organ failure. Most commonly caused by sepsis. So most common reason for MODS is sepsis. Don't worry about the manifestations because it just depends on which organs are shutting down. If your lungs start shutting down, you're going to look at the lungs. If it's your heart, if it's your GI, if it's your brain. It just depends on whatever organs are shutting down. And that is the cutoff for exam 3. Just cardiorespiratory. Okay. Key studying tips. Oh dear God, draw this diagram so many times you are sick of it. Draw it on the exam as well, especially when we start talking about valves prolapsing, regurgitation, talking about left-sided versus right-sided heart failure. Okay. Other key point is this pathway. You guys see what I keep saying? What I kept saying was this is the key to exam 3. This is saying, hey, look, something in your lungs is affecting your heart. Okay. So, question, for example, why would a patient experience edema? Why would they experience peripheral edema with chronic bronchitis? Back up into the body, causing that body's edema.